Good evening, everyone. Welcome to the Health and Wellbeing Board. It is Wednesday, the 19th of November. So welcome to the meeting. I would like to say thank you to Michael for chairing last time. I did watch it and thank you very much. So apologies for absence. So I will go through these, and if there's any others, please just shout out and let me know. So Sarah Story has sent her apologies, as has Martin Kelly, both from York Council. Tom Hurst from the Fire Service has sent his apologies. Andrew Bertram from the hospital sends his apologies. Lucy Brown is going to be subbing, but she's running slightly late. And Naomi Lonergan has sent apologies from Tuve, and Brian Cranner will be subbing for her. Councillor Webb has sent apologies to say he's running a bit late. He will be here. Does anyone have any other updates or apologies to let me know?
You've had apologies from Alison, haven't you?
Oh, yes.
Alison Simmons also sends apologies. Thank you. Okay. So we'll move on to agenda item number 2. Has anyone got any declarations of interest for this evening? No? Okay, on to agenda item number 3. Minutes of the meeting, the last meeting on Wednesday, the 24th of September. Does anyone have any issues to raise about this? No, I will go ahead and sign them then, thank you. Public participation, we don't have anyone registered to speak in public participation tonight. So we will move on to agenda item number 5, which is the Healthwatch York report, the update on the recommendations in previous reports. We have 30 minutes for this item, which includes time to present. And if everyone afterwards could just consider the responses and recommendations and whether they're satisfied this or we would like to look at anything further. So Sian, thank you very much.
Thank you, Chair. And this could be a record for running ahead of running time, because I don't intend to talk to you for very long tonight, you'll be pleased to hear. I'll keep this pretty brief, but last year we agreed that it would be helpful if each year we looked back on the reports that Healthwatch had put together, the recommendations made, and pulled together the responses received to date from partners, just to get a sense of what has been sort of changed as a result, or what work is ongoing that directly relates to some of the themes and trends coming through the reports. So that is what we've done here. I assume you've all seen the report. I assume you've all read it. I think it would be fair to say there are clearly still some gaps in who we're asking for information from. So some of those gaps got filled at very short notice. And one of the colleagues from the Integrated Care Board at Humber and North Yorkshire sent through something else that she said would be really helpful for us in the timescales to just see the sorts of work they're doing around children and young people's mental health as a response to the core connectors work and the listening to neurodivergent young people. So I've included that delivery plan in whole, which isn't a direct response to the recommendations, but does give an indication of the work going on. I think as well, it's important to say that Lucy and I have had a conversation about the responses to the GP reports, and those were only shared with representatives at meetings like this one. But I think we probably need to share it directly with the GP practices themselves to make sure that they all have the chance to respond. For example, I know that Dalton Terrace were in our annual report quoted talking about the work they'd done to review their signage and their website in line with these things, but technically it's not come through as a response to the recommendations made. So it's just kind of how we join up some of that. But on that note, I will stop and see if there's any questions. Thank you.
Thank you, Sian. Yeah, and that was my concern around some of those responses. I think we knew that people had done some really, really good things, and I didn't want them missing. I think, yeah, we can capture those. So would anybody like to raise anything in relation to this report? Councillor Runciman.
Thank you. I thought it was a very interesting feedback, and thank you for putting it all together. I think my biggest disappointment was the section on page 52 about transition to adult services. Now, that's always been a beef of mine, as I think you probably know. It's a time when things can go drastically wrong, as we found in the past, very sadly. And I would hope that that could be chased up again, because both organisations perhaps might respond to it. I really would not like the same sort of incident to happen again, because that transition is wrong.
Thank you, Councillor Runciman. Would you like to respond at all,
I
Sian?
think, again, it's one of those areas where we know there is work going on, but actually to document that, to enable people to be fully sighted on what is happening. I know there's been a huge amount of work done with Parent Carer Forum York, for example, to look at transitions to adulthood and preparing for adulthood. So, yes, I would thoroughly agree. We need to know a little bit more. I am sure there are people who can give us those answers, so I'll just reach out again and see if we can get a little bit more about that. I'm happy to bring that back here if that would be helpful too.
Thank you, Councillor Runciman. Peter.
Yeah, thank you, Sian, for I guess both the work that Healthwatch obviously does throughout the year, but for this process that we have in general, that we don't write recommendations and then they sit on a shelf and we don't actually come back to them, which is, I think, really the strength of this process that we've got here. And it's really a question on that process of whether, and yet forgive my forgetting this, I do obviously read the reports, but do they always come and say the organisation that the recommendation is being made to, or the group? Because there may be a slight issue with some of these recommendations are obviously quite long term, and there's that sort of by when question, but also making sure that we can hold organisations to account by saying this was a recommendation to you. I feel sometimes I can recall reading some of the spreadsheets have been sent out and thinking, I'm not entirely sure which one of us is going to take ownership on that. And the worry is if everyone thinks that, then no one does and you have a gap. So just wondering, is there something we can tidy up there to make sure that when the original reports get published, it says the specific organisation, so we know we need to respond?
I think it is one of the really challenging things when you're putting the recommendations together to identify exactly who should be the owner of those. But I do agree, it is a challenge, and we have tried to make it more clear who is leading them. But some of these things are partnership things that can't be done by a single organisation. So I think it might be helpful as well when we're considering any future Healthwatch reports where we've got the recommendations in there. If people have any concerns as partners around the table about how those recommendations should be taken forward and by whom, we agree that before we get to the point of chasing people up for responses, so that we're all kind of doing the same work, knowing who's going to be responsible for what, without making it too complicated. Because I think we could send it out several times and ask people who they think should lead on it, and we probably get different answers depending on who's got what going on at the time. So yeah, let's try and make that easier for ourselves by bringing it as part of the conversation about reports generally.
Yeah, thank you, Sian. Michael, I'll bring you in and that, yeah,
Thank
you.
So it's just where there are gaps in the report, because, and it was particularly noted, Councillor Runciman's one, I had no response from the council or my own organisation, some of which I think might unfortunately be a bit of a timing issue, because I have got something that we could potentially share. What is the process for following up on where there were gaps in the responses to date? What happens, and is there anything more that we can do to fill them in?
So at the moment, Tracy emails out to all of the partners with the recommendations on a spreadsheet and says, please respond by this date. Yeah. We then gather those responses together. But this time around, I actually then sent a follow-up email, not with a huge amount of time, but just saying we haven't had a response about these issues. And some of those were picked up at that stage, but some weren't. Now, I absolutely agree. And actually, this report last year came in July with our annual report. So it is later for us sending it. But I think we can all understand that in the system at the moment, there is quite a lot going on that pushed back our writing of the report, and that pushed back our sending of the report as a sort of, this is what we've got so far, is there anything missing? But I think we can refine that process. sort of to give people an extra opportunity and plenty of time. I think it was originally sent out to people in May for responses for the July Health and Wellbeing Board, and then it slipped a bit, but I sent out again in October to say, if you haven't already responded, it would be lovely to hear from you. And that was when we got the response from Humber and North Yorkshire about the children and young people's mental health, and their delivery plan was ready at that stage. So in some ways, the timing is always not ideal, but you work with what you've got. And I think sometimes if we've just got a message that says there is some work on this and we can bring a further update.
And when.
Yeah. That enables us all to know what's happening. So, yeah.
Thank you, Sean. And that seems to bring it in quite clearly for how we can ensure some answers from a wider range of sources, because I think that's what we're discussing, isn't it, really, that it needs to be probably specified to the people who are going to reply, but particularly it was GPs that I was discussing, looking at kind of a wider range within that. And is that all a realistic possibility, do you think, within that, to get those responses?
Yeah, I think as long as we're sort of clear who in the system is working on what at what time, it should be entirely doable. I think we've tried in some ways to sort of shorthand it so that it's not going to everybody across Humber and North Yorkshire every time, but maybe we need to just expand and then reduce if we don't need to send it to everybody, if that makes sense.
Yeah, absolutely. And I think Peter did mention a risk within that as well. If it goes to everybody, no one does it because they think it's someone else. So I think that's where within it comes specified who we think should be doing that. Yeah. Okay. Did anyone else have any further comments to make on this, Councillor Colwick?
Thank you, Chair. My colleague, Councillor Runciman, has picked up on one item on page 52. There's another one there which surprised me, and that was in response to C4, reference affordable social community spaces. The response there draws our attention to Castle Gateway and the Eye of York. It seemed a pretty inadequate response. Is there any update on that, or it just seemed to be missing the point?
I think that's why we bring the responses here. So if the board feel that a fuller response to that would be more helpful,
I think it would be very, very helpful.
especially at a time where there are other things kind of bubbling up that might feed quite nicely into this agenda in terms of thinking about inclusive, affordable spaces for activities, for kind of health generating lifestyle choices stuff, then I think it would be really helpful to kind of agree that we want more detail on this and take that to the relevant people. And I'm sure there are people around the table who might have some suggestions for who could help with that.
Thank you, Sean. Peter, did you want to come in with that as well?
Yeah, thank you. But for that question, Councillor Culligan, it's really helpful actually, and without meaning to jump too far ahead. In March, the board is going to not have its formal meeting. It's going to have a workshop which is led by the LGA on our development as a board, and I think that's the information being circulated. But one of the things I am looking to in that, coming out of our public health team peer review, is our peer reviewers noted that health and wellbeing boards generally tend to focus on the wider determinants of health in the new landscape where ICBs have place partnerships that look at the NHS. And something, just not to prejudge the outcome of that workshop, something I'd like us to be focusing on a board actually are the things which create and make health, thinking about housing and green spaces and those things. Not that holding the NHS to account isn't going to be a part of what the board does in terms of its work, but actually that's what a lot of other health and wellbeing boards are focused on. So as part of that, I think it would be interesting to start bringing more items to this board, because when was the last time we did have a focused discussion on housing or a focused discussion on planning or those sort of things? Actually, this is a good sort of forum for that. In terms of the actual recommendation and around green space, the council has published a list of what are called supplementary planning documents it'd like to bring forward, one of which is called a Healthy Spaces supplementary planning document that is in production at the moment and will cover aspects of this. So that is an ongoing process, obviously only with a local plan signed off at the beginning of this year. That takes quite a bit of time to get those documents, first of all, consulted on after they've been produced and then published. So it's a work in progress, and I probably agree that 2 or 3 lines for such a huge recommendation and only focusing on one particular development is actually probably not quite enough for that particular recommendation. You probably want a much fuller answer, so we can certainly come back in future to discuss those things.
Thank you, Peter. Sean, did you want to come back on any of that, or was that no?
No, I think that was really helpful discussion, and I think we can
Okay.
improve on a few things.
Yeah, thank you very much. Thank you, everyone. I think we've discussed how some of those can be moved forwards, and we can look at that moving on forwards. Okay, so if everyone is all right with that, we can move on to agenda item number 6, and that is the Health Protection Assurance report. We do have 20 minutes for this, including time to present. Peter, if you would like to present this report, and then we are invited to receive the report, so can have a discussion around this. Thank you.
Thanks very much, Chair. So this report comes every year to the Health and Wellbeing Board, and it's one of the key statutory functions on the council about protecting the health of the public, and on me in my role. The reason it comes to this board and doesn't go through another council committee route is that even though it's a statutory duty of the Director of Public Health to protect the health of the population from hazards that are harmful to health, many of the partners who help me to do that sit within the NHS and other agencies. And in fact, one of the reasons we take quite a comprehensive approach to this is in part a response to what some could argue is a little bit of a fragmented system when it comes to dealing with infectious disease. Now, actually, when it works together well, I think it does work together really well. However, the organisations that are involved in protecting the public from not simply diseases that are hazardous to health, but environmental hazards are quite numerous. So within a council, you even have different parts of a council that have a role in this. Colleagues that work in air quality don't sit in the same team as those who work in food standards, who don't sit in the same team as public health. And that's just within our council, and that's quite common. It's not sort of limited to York that might be the case. And then, of course, you have people working for the Integrated Care Board who work in screening and immunisation teams. They have recently been transitioning from NHS England into Integrated Care Boards. You have the UK Health Security Agency, which is a national agency, an arm's length body of the Department of Health and Social Care. And then you will have teams working in, for instance, Harrogate Acute Trust, who are responsible for doing infection prevention control in the community settings, and every NHS body which delivers care has its own infection prevention units, teams, statutory duties. So there's lots of people involved. The legislation says the Director of Public Health has to be assured that it all fits together for an area and a place, but actually there's only 1.5 people in my team that do health protection. It's not simply up to them and our team, it's to bring it together. So that's to say that's why you get a report every year, just to demonstrate that all the different bits of the system, where they're at, where the red flags might be, and how it's fitting together. And I would say this year, actually, I think there's quite a high level of system assurance that it's working well. I think there are always things we could do better, but I can point to 2 incidents that we've had in York that I'm not able to go into the specific details on, but a couple of incidents just over the last 2 months which have required significant partnership working together. One particular incident working between a screening and immunisation team in the ICB, the council's public health team, the UK Health Security Agency, who were overall responsible and managing the outbreak, and then one of our higher education institutions. And that, as an incident, I think has been managed so far exceptionally well, with system partners getting together and actually within 24 hours being able to mount a response when it comes to antibiotics and vaccination of contacts. All the things we remember from COVID, contact tracing, finding and isolating people, getting advice out to them and giving them a vaccine. Those things all cracked into action just out of nowhere. And I think we're a testament actually to lots of people who pulled together those things. So a really good lived example of how it has held together recently. So I won't go through the report in detail, but I'd say that the summary message is we seem to have quite good system working around health protection in the city. There's a few bits of positive news in there. So our screening for a number of programs seems to be working very well. We've been concerned for our older cohort for cervical screening and the entirety of abdominal or aortic aneurysm screening, which I think I'd mentioned last year. Both those indicators have improved this year, which is very good. We're also aware that our vaccine uptake can always get better. I think York generally does sort of middling to well in most childhood immunisation, but we still always have to remind ourselves that there aren't any programmes that go above the 95% threshold. Nationally, we don't vaccinate to the extent that confers total protection on the population. And that's why you get, for instance, large-scale outbreaks of measles that happened in Leeds over a period of 9 months, took up a huge amount of community work, public health work, other medical professionals having to respond to a large measles outbreak. So it does happen, and we're nowhere near our 95% coverage for our 2-dose MMR. However, some of our vaccination statistics have got really have done well. I would say so far our winter vaccination is going quite well in terms of uptake compared to last year, which is really good. In terms of winter, people probably may have heard that we have a slightly different strain of influenza this year than we might see normally. So typically we see H1N1. This year we're seeing more predominance of H3N2. It has a slightly higher virulence, so essentially the extent to which it causes a bit of harm, and it seems to be spreading a little bit more rapidly. Although I would say actually it's spreading earlier, but we actually don't know if it's spreading any faster. So what we are seeing is that it's 2 to 3 weeks ahead. Usually flu cases start to get a bit higher about now, get higher through December and peak in the first week of January, often after we've all had Christmas and New Year together and spent a lot of time socialising. We've seen that rise happen towards the end of October and the beginning of November. Every Friday we get statistics on that, and actually last Friday the flu rate didn't rise, which was good because that's essentially a tailing off, but we don't know if that's just a blip and it will continue to rise. So there's nothing suggesting flu will be higher, but it will be earlier this year, and it may be higher. We're going to have to wait and see. We're doing a lot of work on vaccination and would use this platform, as I do every single time, to encourage everyone eligible to go get a flu vaccine and to really prioritise those programs, particularly for our health and social care staff. A couple of other things. Recently there has been a national tier 1 exercise around pandemic preparedness. So we have had a lot of partners across North Yorkshire and York meeting together in 3 different phases to discuss what would happen if we had a situation similar, but actually the scenario was different because they wanted to test us to an emergent strain like COVID. So that was a 3-phase exercise, took quite a lot of time for lots of officers, but loads of people attending from the police, from fire, from Environment Agency, from Animal Health, from councils, from all our NHS providers. So there'll be more, I think, nationally in terms of what some of the learning was out of Exercise Pegasus, because it wasn't just us who were part of it. We were responding actually to an evolving scenario that had been played out in Whitehall a few days before. But just to note that there has been a lot of talk around our preparedness for for pandemics, obviously we've had the COVID inquiry, which is now reported on module 1 and has had a number of different reports on children and young people most recently, for instance. So obviously there's still a lot of effort goes into trying to make sure we're ready if there is another global pandemic. 2 or 3 more things before I finish. Antimicrobial resistance, I just bring it up because I don't think I've brought it up in my time so far with these reports, and it's always in there. It's another thing on the horizon that is exceptionally worrying from a global health perspective, alongside climate change and all the other health threats that we have, pandemics and the like. Antimicrobial resistance is responsible for more and more deaths every year globally, particularly in the UK. The types of challenges we face are the classic antimicrobial resistance in healthcare, which would be your C. difficile and your MRSA, but increasingly blood-borne resistant bacteria, which are responsible for lots of deaths per year. And really, we are facing a situation in which a lot of common antibiotics are on the verge of becoming redundant. There is an awful lot of research now that is slowly creeping into motion in terms of the production of new antibiotics. But I think there are things that we can do preventively, and we mustn't lose our focus on things like good prescribing, both prescribing in primary care, pharmacies' role in antibiotics, and agriculture, which is a big producer of antibiotics in terms of cattle and herd and that sort of thing. I'll draw attention to oral health. There's lots of good things in there, but I will just say in our January meeting, we are intending to bring to the Health and Wellbeing Board a paper on water fluoridation, which will, I think, hopefully be a really good discussion. And my opinion on it is that it's a highly effective intervention to improve the oral health of our children, and it is very safe, and certainly am very much someone who would recommend water fluoridation. We're going to have a chance to discuss it in January, so it's not probably the time to do so now, but we're presenting lots of evidence and lots of things. I just wanted to give people a heads up about that. I wanted to quickly mention air quality, just really to say from a success story point of view, this is probably one of our big ones from public health perspective. For the first time this year, there's been no area in York which has risen above legal limits for nitrous oxide, which is a brilliant indication of the journey we've been on to improve the air quality in York. It still, we think, is responsible for between 80 and 90 deaths every year in York. So it's a big killer, leads to a whole host of health issues, but the air has steadily been getting cleaner in York, which is absolutely fantastic. And the report lists a large number of interventions, from the electrification of the buses to our fleet, to the work that we've done in terms of traffic management, to work we've done on indoor air quality. A couple of officers in the council, Mike Southcombe and Andrew Giller, work tirelessly on this, and I really would like to praise them for exceptional work they do on air quality. That's probably all I'll pull out, Chair, so happy to take any questions.
Thank you, Peter. Can I just check one thing that you said? Antimicrobial resistance, the same as what we generally call antibiotic resistance.
Apologies. Yes, absolutely.
Thank you. Thank you. Right. Would anybody like to?
Nobody else.
Yeah, I'm just going to say I can. Councillor Runciman, would you like to?
2 questions. I'll save the fluoridation questions for January, but I've got a question about the vaccination catch-up. Do we have any resistance to being vaccinated that we have to overcome before we can get the children vaccinated?
Can I just clarify the question in terms of resistance, Councillor Runciman? Do you mean to biological resistance,
No,
or
I mean
within the population?
Cultural as well, yeah.
That's a really good question. I mean, the view generally in the public health community is that of the people who don't get vaccinated, the large majority are issues around convenience and just plain forgetting. That I'd say probably 99% of people who either haven't taken the vaccine themselves or their children haven't yet been vaccinated. It is that life is very busy, stressful. There's lots of things to think of, and we just haven't managed to reach them with the most convenient offer. There will always be some resistance to vaccines from a scientific point of view. I mean, I'd be the person who'd come up against that fairly regularly, and I have to say it's very infrequent that people raise that with me. It does happen, and we have to just always stick to the science. But I would say that most of our efforts should concentrate on how do we make it as convenient, how do we remind people and give them that little nudge, and that will probably get us across the 95% line, I'd say.
Hope so. Good. One more? Yeah.
Yeah.
I just want an update on the Henry programme. It was something I pressed very hard for when I was the executive member, and I can see it's happening, but is it going to expand? Do you think it's being successful?
I can certainly update on that. And I think there is going to be a paper again in January,
Can we just
actually.
explain really briefly what it is?
Will do.
Thank
Yes,
you.
I think there will be a paper in this in January. So Henry stands for Health, Exercise and Nutrition in the Really Young. So it is a programme that's very well evidence-based now and is gaining increasingly good impact. There is a national evaluation actually led by the University of York, so that's fantastic. It is a whole family-based programme around helping every member of the family, and particularly children, to maintain a healthy weight, to achieve and maintain a healthy weight. We are running Henry in 0 to 5s, and we are planning to sort of slightly prejudge the paper in January, but we are planning to expand that into the 6 to 12s category now. It's gone very well in York. We certainly have numbers in the paper, so I can't reel them off the top of my head, Councillor Johnson, but we've got some good data now, some good families who've gone through it with very positive experience. And so we are looking as part of a broader Healthy Families approach to make Henry more widespread and to take it up to that sort of school, the secondary school age. So hopefully a positive update on Henry.
Yeah. Thank you, Jack.
Thank you. Thank you. Sian.
I just couldn't miss an opportunity to talk about dentistry and dental care, because you mentioned the oral health word, and I see that there's some good news in there about us getting some data on the oral health of our young people. We now have a plan to do that, which I am really happy about, because I know we were concerned about the statistics for York, that despite the fact we are seen as a relatively affluent population, we did have far more children under 5 than you'd expect having teeth removed in hospital because of the decay. And I know we are still struggling for NHS dentists in the city. We still don't have enough. I overhear people every day talking about how they've given up on ever having NHS dentistry. So I don't really want to ask a question, but I just wanted to say I'm really excited that we are getting that data.
Yes.
And I hope it gives us a better picture than I'm expecting, because of the work we've put in schools, because of the work we're doing to give people access to oral health education. But I do think that dentistry remains a serious challenge for our population. And there is great things that public health work can do to improve that, but we still need more dentists.
Thank you, Sian. Completely agree. Would you like to respond to any of that?
Sian said it all.
There's something I would like to discuss. We could look at any of them, but I'll take cervical screening, for example. And there was some work done to focus on groups not uptaking who face more health inequalities. I wonder if you could just speak about getting people, the work that's going on to engage people more who are probably less likely to attend or engage.
Absolutely. So I mean, we've done a lot of work in sexual health services, including the provision of a clinic at Monk Bar there, and that is really important from a inequalities perspective. It won't tackle everyone, because obviously people who turn up to sexual health services are generally turning up with a contraception query question, looking for contraception advice and help, and sexual and reproductive health issues, STIs, that sort of thing. So that won't be absolutely everyone. We have had the report talks about Priory Med, and it's the group, it led a project where we got some Cancer Alliance funding to increase screening uptake. It linked to that was a I mean, there's lots of kind of campaigns there. There's lots of proactive work that primary care is able to do, because what primary care can do very well is to come up with that group of people who are on the record system as having had a screening test. So they're able to proactively reach out, and you talk about this sort of the birthday card approach that they're sort of taking. I think in general, screening around this will change over the next few years, and I hope that will iron out some of the inequalities. The two big things that are happening are home testing, which is probably going to come probably going to start fairly soon. The longer term thing is that we are now going to have a generation of women who have been through HPV vaccine, and that will probably change the screening interval. We have to screen less regularly because there's more protection in the population. So because of that, we hope the great thing about vaccinating people aged 13 in schools, even though it still doesn't get everyone, of course it doesn't, there's plenty of children who are not in education at any one time, but it in general is a more universal intervention, and therefore the problems you have later on in life that certain groups don't come forward or we're not very good at reaching them is less of an issue because they have that latent protection. So there are some things that the PMG primary medical program is doing to actively reach out. The provision in sexual health, I hope we are tackling the inequalities through those things.
Thank you. I was going to ask if the HPV vaccines would affect that, and I couldn't find an actual definitive answer yet on that. So perhaps it's not quite decided. Did Councillor Colwick was?
Yes, thank you, Chair. Just a quick question, something that's not actually referred to, but I'm not sure how far it's part of your brief, but in terms of environmental health and hygiene, public toilets, is that something that comes within your purview, and in what way?
Not really, no. In terms of provision, I guess, I mean, that would sit more within our environmental services bit. And I guess this report very much focusing on threats to health from infection. I wouldn't see those settings as any more dangerous than other settings. You know what I mean? So the provision of, do we have enough in the centre? Absolutely can see how that would link into health. But it's, I guess for me, it's probably more of a wider health thing rather than a health protection and an infectious disease, if that makes sense.
Probably guess I'm asking the question in the light of a sort of recent report that's been in the press highlighting the poor state of many of our public toilets serving the city centre. And given the other references to visiting premises and identifying risks with Legionellas and so on, I wonder whether that was something that was within your
So what happens within the environmental health, our environmental health team, is that they have quite specific things in law that they are responsible for ensuring and enforcing. So particularly any premise that serves food has to gain a food standard certificate, food safety certificate, and that is the majority of the work that they do. Legionella is I guess is the one area that will cross over into public toilets, and certainly everyone who is, you know, public body or a business that is providing water and is having customers onto the premise, that is a potential in terms of the you know, the sort of the potential for Legionella infection in the water. They will have sort of legal liabilities around that as well. So in that sense, yes, I guess most public toilets would generally be council public toilets, and therefore, in a sense, they'd be part of our health and safety work, which again isn't precisely within the report. So I'm probably not as well briefed as I could be, but happy to bring anything offline in terms of any queries on that in terms of public toilets, and we could maybe talk about that offline.
Thank you, Peter. Sian, did you want to come in?
Sorry, yes, I know I've already had a go, but I just wanted to add that Healthwatch England did some work around cervical screenings that we in York contributed to, where we were interviewing people who were less likely to have taken up screening opportunities and trying to look at some of the barriers. And there was a lot of support for the home testing. People were very keen on that. So I'm really excited to see that come along. But it also reminded me, I wanted to ask you a question about air quality. And I know you said we've done huge work in the city. I think the change to the bus fleet has been incredible. You can taste the difference on your commute to work, which is lovely. But I did wonder about what influence we have, because I was on a bus earlier today that is one of the ones that has travelled in from outside our area, and one of the children on the bus referred to it as the dirty bus. And I wondered what influence we have, especially now we're part of the mayoral combined authority who have more control over transport than potentially we do, where it's crossing boundaries. What influence we could exert to make sure that all of the buses in our city are clean buses, not dirty buses.
It's a really good question, Sean, and it's a good prompt for me to take back to Mike and Andy and the team. I mean, obviously, so they're diesel buses are going to be the worst. Electric buses are going to be the best. In between are these Euro 6 standards, which are much cleaner. And I know we've made quite a bit of progress. And for instance, our park and rides are all at that electric end. A lot of our first fleet is definitely meeting that Euro 6 standard. You're absolutely right that actually some of this is regional and not just city. And also, as a council, we will provide some subsidy, and there will be some services that we are responsible for, and we're very much responsible for some of the sort of the planning and the information advice, that sort of stuff. But these are external companies actually providing the buses, and in that sense, it becomes an influence thing. And so what I can do is take that query back actually and just ask what the progress would be on trying to influence those sort of buses coming from the further away in order to make sure they're as clean as possible. One thing I would say is that whilst wouldn't want to lay it at the door the individual to take all the action, a lot of this is on companies and public authorities to make sure our air is as clean as possible. We do have an air quality alert system that we put in place, and particularly on days where air quality is particularly bad, you sign up to that, and if for instance you have asthma or COPD, you will get a little text message telling you actually you need to watch out. Just as a kind of health protecting piece of work, I think that's a really positive thing. Again, in the report, it doesn't solve the problem. We want to clean the air fundamentally, don't we? But actually, it does provide people the information that they can take action on, which I think is a really positive thing.
Thank you. Anybody have anything else to say on that? No? Okay, so thank you for that, Peter. And I believe the next item is yours as well. Agenda item 7, the delivery of the joint health and wellbeing strategy and performance monitoring. Goal 6, we have around 20 minutes for this. So if you would like to go ahead, thank you very much.
Thanks. I'll introduce this, and it's a pity Alison isn't here because Alison has some things within this, but I know there's some aspects around some of the poverty work that Pauline will take a view on, and some work around inclusion health the ICB have led that Michael might as well. The point of this report is that we have a health and wellbeing strategy. It's got 10 goals within it. And what we said right at the outset of the strategy is that every 2 years we'd circle round the goals, and we provide an update report that tells you what's happened on them. At the start of each 2-year cycle, we set a set of actions. So it may seem like the actions here are quite, if not limited, they only cover a certain amount of this particular goal, but that's because we're doing 2-year cycles, and across the course of the 10 years, we hope to have done a broad range of actions, but each 2-year cycle, we're only putting in place 2 or 3 actions for each of the goals. So what you've got here is goal 6, which was our big goal around inclusion health, reducing health inequalities in specific groups. And what we said in the strategy was examples of those groups were for people who have a severe mental illness, people who have a learning disability, gender health inequalities, and your what are known as inclusion health groups. So for instance, those who are homeless in their health, people with addictions, people from Gypsy, Roma and traveller communities, those who we know typically experience the worst of health outcomes in terms of life expectancy. So it was quite a broad goal around those groups, and a number of actions that we brought to the board at the start of the second 2-year cycle, which I think was about a year ago now. Action 18 was implementing a community-based intervention to reduce health inequalities, focused on children and young people. The action updates on the children and young people's priorities and work plan for York, and the fact that that's been developed, and then gives a bit of an update on the main project the action is focusing on. And again, it's very close to York CVS, and it is a shame Alison isn't here, but essentially the ICB and the Council's Public Health team have been working together to fund a programme of work that we're hoping the voluntary sector will deliver for us as a system. The goal is to try and reach those who suffer health inequalities and families who suffer health inequalities, to give them some really rounded and holistic support. Essentially what we wanted to do as system partners was to give the third sector the chance to really shape that around a group that they felt was important, and to co-produce with that group what it looks like. So it may sound like a deliberately a vague project. It is deliberately vague because at the moment we're at the co-production stage with the York CVS. So CVS are putting out essentially an expression of interest for us on that particular project, it says here a lead VCSE delivery partner will be appointed by the end of November. Mike might have an update on any of the timings of that, but I think we're broadly in line with where we've got to on that particular project. So that's a bit of a work in progress. Happy to take any questions on it. Action 19 was about chronic disease prevention in our Core 20+5 groups. That's an NHS initiative, Core 20+5, which essentially says the NHS wants to devote more of its resources to the Core 20. That's people living in the 20% most deprived areas, people in plus groups, inclusion health groups, and in 5 key clinical areas, which are essentially the 5 big killers, the things which kill us. So cardiovascular disease would be a good example of that. There's going to be very good progress, particularly in the way primary care is able to identify people living in inclusion health groups. And as you can see on the chart that's in your papers, there's been a huge increase in the way primary care is recording simple characteristics of people in inclusion health groups, which is really important because it's the first step when it comes to the improvement in those people's health. Of course, it is only the first step, because knowing someone, for instance, is from a Gypsy Roma traveller background, knowing someone is a care leaver, knowing someone is a veteran or has experienced homelessness, is only knowing that they have. It's not actually taking any action. So it is the right first step, but it's not the totality. What is now happening is the Integrated Care Board is putting out an inclusion health locally enhanced service, and that will encourage our GP practices to do a number of things. It will provide training for general practitioners on how to better reach and serve inclusion health groups. It will provide an annual enhanced health assessment, training on trauma-informed care, strengthening the care pathways, what we're calling here culturally competent care pathways. So essentially what we're hoping through this is that our general practitioners who are out there every day seeing 90% patient contact in the NHS will be better able and equipped and working more proactively with some of these health inequalities groups. Action 20 is around the Poverty Truth Commission. There was a set of standards that came out of the Poverty Truth Commission. I know Pauline was on it and knows much more about it than me, but that was a fantastic thing. And if anyone hasn't seen the video that was produced at the end of it, that had lots of people's sort of stories and testifying to how important it was a really important piece of work. And one of the core bits was a really simple set of standards of how should we deliver to our population kind, compassionate, responsive care and service. And the council has adopted those standards. We know lots of other partners have been considering them. We know as the neighbourhood model is being brought forward in York, we're actually wanting to put the standards at the heart of the practice that we will work to in the neighbourhood model. So I think under Action 20, there's been some really good work in adopting those standards, and that will continue. And Action 21 is about taking Poverty Truth Commission further and establishing it for children. Again, York CVS would comment a bit more closely on that, but we know that is a piece of work that is under development at the moment, and certainly can bring back to the board further updates on that. But we're really hoping that that piece of work will happen in the next few months. A Poverty Truth Commission for adults will look very different to a Poverty Truth Commission for children. We'll need to be creative and imaginative. You obviously have to think about the times of day as well, because you want children to always be in school between the hours of 8:30 and 3:30. Certainly want my three to be in school for those hours, but to be able to creatively work with our young people, to hear their experiences of what it's like to live in poverty, to have financial challenge, is going to be really important. So we probably brought this report, because of the phasing, a little too early in terms of that piece of work, but we can certainly come back and just to give an update when that has happened. So thanks, Chair. I'll stop there.
Thank you, Peter. Did anyone want to add something? Councillor Webb, did you want to?
Yeah, thank you. Apologies, Chair, for being late. I was stuck at work doing work things. My question is around the annexes, because you've got some of the data in there, and I just want to just unpick a little bit about that data, because I think firstly on Annex A, are they really the three sort of measures that we've got, really? And it's obviously it's very focused on one particular aspect of what you've been talking about with sort of different groups of individuals. It's mainly around, so you've got mental health and learning disabilities. And I suppose my first question really is, what else could we measure? But actually, the second question is, within the learning disabilities, that there is a huge range of what would come in that category, right? And as we can see, there is quite a large difference between those in work who have learning disabilities and those who do not. And I wonder if we can break that down at all. That would probably be a bit more useful, so we can then, target proactively certain groups. That's my first bit. I'll stop there.
Thanks, Councillor Webb. As is sadly often the case with public health data, we measure the things we can measure, and that's the difficulty, because you're absolutely right. This is a really broad goal, isn't it? Reduce inequalities across our inclusion health groups in the city. It was always the risk of having this goal in the strategy, but I think it was justified, because actually, if you look at people who fall into any of these groups at any age, because these groups obviously do include lots of adults, but also lots of families with children living in poverty, etc. The outcomes are just so much worse. Life expectancy outcomes and on all those high level, but lots of lower levels. The problem is then having including in it. I'd say this is the one goal that I wasn't satisfied with the data we were able to put into the scorecard. It was the best that was available. So, for instance, if we wanted to bring any data on the health of those who are homeless, or any data on health of our gypsy traveller communities, there's simply no national validated sort of piece of data on that is then broken down by local authority, so we can see how York is doing. So these were the ones that were available at York level, but I'd say let's not take this as an indicator of how we're doing. We have included a little bit of data in the report, therefore, but I think maybe the feedback would be, in future iterations of this, we probably need to go a bit further in some of the things we could measure, even if it's only anecdotal or qualitative about some of these things. And I'd welcome suggestions as well, because sort of mindful that public health, we produce this report, but we're not the single source of truth on all of these things. So there may be pieces of data that partners are aware of that they'd like to throw into this. Really welcome that, and we can certainly produce it. When it comes to the gap in employment, again, that is essentially pulling from a couple of national data sets on people who have a code of within primary care of having a learning disability, and employment data, and even those are quite hard to match up. So in terms of can we bring that even further, probably internally within social care, for those who are eligible for care and have a learning disability as adults, we would, as a council, have quite a bit more data on their care and support needs and what we can do. And there are some really good supported employment things that we do as a council, but it's not a comprehensive population level thing, if you see what I mean, that you could say break down a lot further. So I think the data, in summary, is inadequate in this, and we have to work with what we have. But we can try our best and welcome any suggestions for improvements.
Yeah, thank you for that. And I think that's very open and honest to sort of say that, well, essentially you've got what's measurable against other places, haven't you? And that's useful to have. It's useful to be aware of that. But I think when maybe with this particular item, we want to think, well, actually, how do we, what question are we trying to answer? And therefore, what data can we collect? And I think, I'm sort of looking towards Sian, really. I think this is where sort of Healthwatch does add real value in these sorts of things, where we can sort of work together potentially to look at, well, again, what question would we want answers to, and how could we work creatively between what Healthwatch do, but also what all the different arms of the council do with different individuals who fit into these different categories. Essentially, I'm saying, Peter, it shouldn't really all be on public health, this one. I think it's actually, how do we then collect some data in other places to then bring that in, and you can then, your expertise is then sort of taking a look at it and seeing what that tells us. But I'm going to keep asking you because it's your report. So my only other question, if you go to page 138 of the report, well, 137, 138, this is about the excess under 75 mortality rate in adults with severe mental illness. It's a catchy title. And I wonder if you can just talk through some of the numbers there, because firstly, we've got percentages of 478%. So what, in layman's terms, what does all that mean?
In layman's terms, it is a bit of a clunky way of putting the percentages, isn't it? And I'd probably actually rather convert it into a ratio. So if in any one year, my chance of dying, my mortality rate might be something, let's say it's 10 in 100, and it's not. 10 in 100. What we're saying here, so take for instance the overall rate most recently, it says here 478%, but let's change that to a ratio of 4.78. So if my chance of dying is 10 in 100, someone with a severe mental illness has a chance of dying of 47 in 100. So that's the type of level of excess mortality we're seeing. It is essentially a comparison between the chance of dying in any year in that particular population. Now, those were hypothetical numbers, the 10 and the 47, but that's the ratio. That is obviously, a huge inequality. It's very marked nationally, and it's higher in York. And that's been the case for some time, that we've been higher. There'll be reasons for that, and you could take time to speculate on them, I guess. Within that population of people, we know that, for instance, excess causes of death might be from additional heart attacks in any year. Again, a number of factors to do with that. People in that group may be more likely to smoke, and that probably actually is quite a large proportion of this, which is no comment necessarily on sort of social comments, more comment on how dangerous the cigarette is to your health. There are going to be other sort of factors within that. For instance, people less likely to immediately seek medical care when experiencing cardiac symptoms, potentially less likely to be believed by medical professionals. I have to be very careful what I say here, because I'm making large generalizations, but I think we do have to think that inequalities like this will be a combination of structural factors, cultural factors within medicine, factors within lifestyle, but it is an injustice that those types of rates are seen. that really is quite huge, isn't it? A 4.7 times mortality. And yeah, others may have sort of contributions in terms of where that will come from, and Brian would comment on that. But certainly it's multifactorial. I don't think you could say there's one thing which leads to that injustice, but it is very high.
Yeah, thank you, Peter. It's kind of why I asked the question, because when you look at those numbers, there was the science teacher in me is thinking you can't have more than 100%, right? And we shouldn't have more than 100%. And straight away but you've highlighted what the real issue is there. And I think that actually everything you've pointed out there, that are hypotheses, you don't necessarily know, but you sort of suggested a few for different groups. There's your questions. When we're saying about what questions do we want answering, I think for me it's okay. We're looking at Gypsy Roma traveller community, for example. What are the health inequalities there that are leading to changes? Right. We're looking at severe mental illness, which is that particular category there. How are we looking at those subgroups, and how are we working with partners in different organisations to sort of get a bit more evidence that then helps what we do proactively, whether it's us with public health, NHS, etc. So I wonder if there's a piece of work in there really to sort of say, well, how do we break down some of those and get some more validated data?
Thank you, Councillor Webb. And I think within that as well, I'm also thinking there is a big role for the voluntary and community services, who often have a lot of contact with people who aren't having contact with mainstream services. I think that is a big thing to all do together. Brian, did you want to come in?
Yeah, certainly. Just in terms of severe mental illness, some of the key strategy of the trust round about mental health services is to address those health inequalities and ensure we support people's access to appropriate primary care. Sorry, yes, certainly. I'll move that to one side. That's probably better. We've got a particular focus round about physical health care and supporting people who access our services, particularly our inpatient services. And we've got far more physical health practitioners now working alongside supporting people with severe mental illness, both during that inpatient stay, but to ensure they're addressing and accessing appropriate support on discharge as well. It's also a key area looking at around our community services, how we ensure that those services are accessible to communities. And also, again, that where there's comorbidity, lifestyle factors, how we're working with our other partners to ensure people are receiving that rounded support.
Thank you very much for that. Did anybody else want to come in for that? No. Thank you. I think that discussion's been really useful, looking at the inequalities around that and the work undertaken for this goal. Thank you, Peter. So if we move on now to agenda item number 8, and that is the update of the York Health and Care Partnership. Michael is going to present this report, and this is a report for noting. Thank you, Michael.
Thank you, Chair. I'll make sure my computer's not blocking my microphone as well. So yeah, this is the report from the most recent YHCP, which was held early this month. Some really good updates actually that I'd really like to kind of flag. I think the first one is that just sort of generally that the work to continue the progress around neighbourhood health and neighbourhood health working on the back of the bid to be part of the National Neighbourhood Health Implementation Programme continues, and it continues in light despite some of the national changes that's going on around ICBs that has been announced kind of recently, and maintaining that within that group I think is going to be a really kind of key focus. But I think York is well placed to do that and to continue to follow through on that despite some of those national changes, thanks to the good work that's going on with partners around that table. I'm really pleased to flag to you, and it's the second sort of kind of key highlight bit, is that between both my organisation, the ICB, and the City of York Council, we have managed to identify despite some very challenging financial positions, respectively, a small pot of non-recurrent development funding that we're going to make available to that group to oversee in line with the kind of place-based partnership priorities and objectives, and using the kind of existing kind of governance routes in terms of some of the kind of joint groups that we've got across the different programs of work that they're overseeing, to come back with a series of proposals. So that process is effectively about to start to receive those. It is only non-recurrent funding, but it's an opportunity, as I say, to really potentially try some things that that maybe would be difficult to get off the ground, just to kind of start things off, to pump prime some developments, with a view to them having a kind of ongoing impact potentially for those priorities and our population. So that's really positive. The partnership also received, and we invited, in fact, an organisation called Akizo, who are working with the Combined Authority. I think this was really important. They're looking at something called Health on the High Street, that the mayor's been kind of quite key to make one of his real sort of priorities, using our kind of collective assets, buildings, spaces, wherever they may be across the city and across the Combined Authority area. In fact, bringing in an organisation called Akizo to do a sort of, which is an external consultancy firm, to do a bit of a sort of strategic assessment of what those assets might be, where the opportunities exist to maybe kind of do things with those in a different way, and start to provide an initial sort of very sort of high level kind of assessment of that. I think why it was important and helpful that it came to that, the partnership, was to ensure that we're sort of working much more closely together. It was certainly, for me, it was the kind of first opportunity to really start to kind of work a bit more closely with the Combined Authority. And I think that will be really important going forward, making sure, though, that we're not duplicating some of the work that's already going on, that we were already looking to do as a partnership, using kind of consistent data sets across us all when we're making assessments and deriving what those opportunities may be. But it does mean that there's the potential in a more medium term to access some of the Combined Authority funding that they will hold. So I'm pleased that they had the opportunity to come and do that, and that we're now, well, ideally more aligned in terms of kind of some of the work and the joint work that exists on the back of that. So that was really positive. I don't want to steal all of Brian's kind of thunder, but we were kind of also able to update on some of the mental health partnership working. I'm pleased to say that now we have our second hub up and running within the city for the Community Mental Health Hub. This is the one that's linked to the 24/7 national funding that we secured. That has now opened. It opened in mid-October with a base over at Acomb Garth. It's not fully operational in terms of the 24/7 aspect of that. That's been a real challenge, and some real challenges around getting the organisations that are working in that collaborative way, but getting them onto the same systems and things like that. Just really operational, practical things. But it's been great to get it open and up and running, at least for the core hours that we've been able to offer that for. What I would say is we're in I think, I can't remember how many sites there were nationally, Brian, but we're in a similar sort of ballpark. Everyone's struggling with that nationally. We're not the only kind of city that and the only kind of hub for that one that is struggling with some of the kind of operational aspects for it. But we're also probably in a similar place in terms of the rollout of that. So that's really, really good and really positive. One of the key things that I'm working on with council partners is, and Tube, in fact, is around how do we make that sustainable beyond that. So it's a 2-year program, but we're already thinking about, so what would the end of that 2-year timetable kind of look like? How do we make that more sustainable? In particular for the second hub, Hub 1, there is recurrent funding from within the ICB. The proposed Hub 3 also has a recurrent funding stream, but as yet, Hub 2 doesn't. But we are trying to come up with some early plans about what that might look like, and I've got meetings this week, in fact, doing exactly that. I think I'll leave it there for the kind of key highlights.
Thank you very much, Michael. Absolutely agree. We need to make that funding continue, don't we, for that hub, because we deliberately pick the areas so they're equally spread across the city. So it's really, really important. Does anyone else want to? Councillor Runciman.
Thank you, Michael. When the Acomb one gets going, is that when you might look at putting in the same sort of thing for the north and east of the city? Because that's the area now that isn't covered.
I think Brian can add to it if he wants to, but certainly I think the intention is to ensure we've got pan-city coverage, as Councillor Steels-Walsh was alluding to. I think what we're also looking to use that pilot for is to take some of the learning from it. That's why we're really grateful to get the kind of national funding and to look at how we can do that. Fundamentally, I think for me, it goes back to the conversations about the sustainability. So we need to be looking at all of our existing community mental health services across both health and care settings to understand how that all comes together in a more sort of sustainable way. But that is the intention. I don't know if Nigel wants to, Brian wants to add a little bit more detail to that.
No, certainly. I think Hub 3 will cover that area. That's the intention, and that's the work that we're doing at the moment to identify the appropriate location for that hub. And then obviously the hubs themselves are the point of access, the available building in the community where people can come and seek support. But that doesn't mean we're not covering the rest of the city with work into other community locations, people's own homes and other sites that we have. Just to add to Michael's feedback in relation to Cumgarth, I think one of the other areas which may be helpful to actually say in this meeting is recruitment. And we're having some real challenges around about recruiting staff for working during the night. And that's an area we're taking different approaches to that to try and encourage applicants. But it's certainly a message that we want to be out there, that actually we are looking for people to work with us to provide those services over the 24/7 period, and opportunities for promoting that and getting some interest from people would be welcomed.
Thank you. Thank you, Brian. And did you say that was a national thing with the staffing as well? That's not something that's unique to York? Is that something that's happening across the country?
So yeah, I've been on some of the programs. So there's a kind of cohort, a program for all of those national pilots that are being done. I want to say it's 12, but I might be wrong. It's that sort of number, maybe slightly less actually. It's the 24/7 aspect, specifically the nighttime working and that model replicating it nationally. That does seem to be a fairly consistent one as part of that kind of shared learning. That's what people are sort of wrestling with and trying to come up with those innovative ways or different ways of maybe looking to provide that locally, but yeah, as part of the learning of all of those people going through those programs nationally.
Thank you. Would anyone else like to comment at all? Nope. Okay, happy to move on then. Goodness, we are getting through this tonight. So if we move on to the last agenda item, the agenda item 9 is actually mine, the Health and Wellbeing Board Chair's report. I'm guessing you've all read it, but I will go through just a couple of things to highlight on it. I thought, as Councillor Colwick did mention toilets earlier, it was probably worth mentioning something from the Ageing Well Partnership, who have just recently published, and I did find out where it was before the meeting because it wasn't in my report, but it's on the Live Well website. The list of, so it's called For Your Convenience, and it is a list of venues in York where you can go into, you don't have to buy anything. And there's a table on the website which says whether they've got chairs with or without arms, whether they've got a toilet, whether that is accessible, and whether they have got a baby change facility within there. And I just thought that was really, really useful for people who may need that in town and want to go somewhere. You don't always want to buy something every time you need to go in. And on there, I will also mention that there's also an accessible housing checklist, which I had a look into, and it helps you decide whether your home is, well, it helps you evaluate whether your home is a home for life, which I thought was really, really useful for looking into. And just the other thing I wanted to highlight from my report, because of the PNA, is pharmacy changes, and to highlight to everyone that recently the Green Lane Pharmacy has said it's relocating to Cornlands Road. This will mean a loss, I think, of roughly around 40 hours, and it won't be late nights or Sundays anymore, which is quite a loss when you're looking for pharmacies. So a supplementary statement is being prepared by the board, and this will lead to an official update to the pharmaceutical needs assessment. Obviously, we can't force a pharmacy to open, they are businesses, but if there are applications, then this will happen. But just to make everyone aware that we know this is happening, and we are going to raise this supplementary statement. Okay, thank you. Did anyone want to ask me about any of my reports?
Thank you. This is not really a question about your report, but simply to respond. It was, I guess, in part noting when I read through the papers earlier, the reference here to public toilets that prompted my question earlier. And also, of course, the recent rather disturbing report that we're aware of, and which featured in the York Press. But there's a world of difference between offering a seat and offering a toilet.
Oh,
So
absolutely.
referring to 50 businesses is, I'd be interested in more of a breakdown of that. I don't know if you have that.
I've
and
got it
I
here
imagine
from
that many of these will be only through rather limited hours of the day rather than.
Yes, they would generally be while the place opens. And I do have it open, but it's probably a bit big to go through all 50 and make a breakdown. But yeah, it would be limited hours generally while the places were open, and difference between accessible and inaccessible toilets. But yeah, absolutely. Just thought it was worth highlighting that that is in existence. Thank you.
Thank you.
Okay, Councillor Webb.
Thanks very much, Chair. Couple of things for me, really. And one, I suppose, is the recent inclusion conference that took place in the city. I think it's worth just highlighting that that happened, and that was, I attended it myself. And this was attended by, well, there was over 100 people in the room. I had to squeeze in at the end, to be honest. They were from various different schools in the city. It was really, really well represented from both primary and secondary, from maintained schools, from our trusts as well. And the aim of this conference was really to start a decent conversation across the city on how, firstly, what we think inclusion means within our school system, and how we work together to become more inclusive in classrooms all the way through to school systems. And I just think it's absolutely worth noting that for so many people from so many schools to take the time out of what is an incredibly tight day, and what will have cost schools money to cover people who've taken the time out to go to these things, it's worth highlighting it and sort of recognising the importance of that. I think that we're really moving into a much brighter place when it comes to inclusion and belonging within schools. And I think that actually a lot of messaging around that's coming out of the government, it's coming out of Ofsted, which is a rare word for me to use, but around inclusion and belonging is much more positive than we've been previously. So I think it was a really, really powerful meeting. We got to hear from experts from around the country on how to become more inclusive, how to develop and foster a sense of belonging within schools. And that should be celebrated, because I know it's something that we've talked about in this meeting, particularly when we talk around children with additional needs, and how they struggle with access to school, and how that sadly often leads to families sometimes feeling forced out of the education system. And that's not always, but it's certainly something that does happen. And I think that it was great that we're convening these kinds of meetings to bring the different parts of our system together. So that was a big positive. So I'll stop talking about that. My only other point was around infant feeding. And it said in the report, which I've now completely lost, pressed the wrong button, apologies. But it says in the report at a particular paragraph that you're aiming for accreditation, BFI accreditation. I wonder if you can sort of outline a little bit about what's involved in that. And then maybe more of a practical question. Here in the City of York Council in West offices, what are we doing to support infant feeding, or what could we be doing in the future? I don't know who wants to answer that.
Thank you, Councillor Webb. Do you want to start, Peter? Thank
Well,
you.
I can, although we share the role of
Yeah, we do.
infant feeding guardian, don't we, Councillor? Absolutely. I mean, it's really important, and it's such an important sort of thing that sets up for life and health outcomes as well. And I always am at pains to stress whenever I talk about infant feeding that decisions on what sort of mums feed their babies are really complicated. And what we try to do in public health is support people as much as we possibly can. The vast majority of people that don't breastfeed for the first 6 to 8 weeks and into the first year actually would say that the levels of support they received probably weren't enough, and actually some of that advice, that guidance, and then the more specialist stuff can make a huge difference between whether you do or don't breastfeed. So that's really where our efforts are, is supporting and making every space in York a breastfeeding friendly space. The infant feeding process is defined by UNICEF, so an international process to get what's called baby friendly initiative accreditation, and it's very comprehensive and very robust. It requires a number of things to be in place locally in terms of specialist services, as well as universal services. So for instance, childcare and health visiting service and midwifery and those sorts of things also having their policies and procedures in place. It takes quite a long time, and it has 3 levels. What we've done so far is submit our certificate of commitment to UNICEF, and that's been approved. So that's not even stage 1, that's pre-stage 1. So it's going to take a little bit of time, and there's lots of effort that goes into doing this. But we've got a number of significant bits in place which the report lays out. I think, Councillor Webb, you're absolutely right that actually this is very much about looking at major public bodies and workplaces and the places where people may gather and be socially in public, so our libraries and our leisure centres and those types of places, our hospitals, etc., and making sure that mums know it's absolutely welcome to breastfeed in those places, and there is the support for them to do so. We sort of are thinking of it as sort of feeding friendly city, that sort of idea, and lots of other places have gone quite big on that with kite marks and some badges in shop windows, and we're hoping to launch some similar campaigns to that. It's going to take a little bit of time to get that across the line, but having that certificate is a really good first step. So would really love partners to support that, and it's been a conversation we've taken to our scrutiny and people scrutiny has had quite extensive discussions on infant feeding.
And I think within that as well, there's a recognition amongst the support that it's a whole family-based support thing. It's not just about supporting the person who's feeding the baby. Everybody in that family kind of needs to be supported. And I think something Peter's spoken about, which is about the first 1001 days being really, really important for that child, is really, really important at recognising it. So I think there's a lot of recognition, education, awareness as well around this. Did you want to?
Yeah, it's just, I think I absolutely agree with all of that. I suppose the next step is, where is the hospital in this, and the sort of services that are working or not working, as the case may be. And I think it's just sort of getting a clarity on what they're doing to support women and families, but particularly women, I think, around issues of breastfeeding.
Yeah.
But yeah, I mean, I speak for them. I would say that we've had a previous conversation at this board actually about the tongue tie pathway, which I think has resulted in a good resolution for that pathway. And I'm assured now that there is access to be able to have tongue ties seen and dealt with if appropriate now throughout the first few weeks, whereas I think there was something of a gap. So that's one bit of it, but you're absolutely right, it's much wider than that. And bearing in mind, if you think of the journey young families go on, they generally, apart from the initial consultation with the GP, midwifery is who they see from 12 weeks to generally 8 days afterwards of giving birth, and up to sometimes a month if there are particular complications. At that point, health visiting takes over. So we've got a big stretch of that pathway, which absolutely they are the lead professional, and making sure that all our midwives, amidst very stretched and strained services within midwifery, are able to support him for feeding is a key objective. And in fact, we won't get accredited if that's not the case. So it will be an absolutely intrinsic part of this process.
And I think time's so vital in that, isn't it? It's not something, feeding a baby is not something that people can afford to wait for, can they? Because you need to feed them. Yeah. Yeah. So yeah, the timing is so important in that. Yeah. Okay. Does anybody else have anything? Sian?
I just think to add to that, I know it was an issue that came up through the Women's Health Report we presented back in July. I know it's an issue that comes through the Maternity and Neonatal Voices Partnership. So I think it's just, when this work is going, how we get those messages out, how we make sure that, as you say, that support is timely and it's the right person giving the right support at the right time to actually help the family with the situation they're in. Because I think a little bit of understanding, compassion and support at that time is really important. This is not an easy thing for people that it doesn't work for immediately. It should be an easy thing for virtually everybody, but it isn't. And I think if anybody puts more pressure on you and makes you feel like it's worse than it is, that is the least helpful thing that can happen. So I think it's just that sort of understanding of the importance of compassion and support at that time. Because most people want to do it, and when they can't, they're as frustrated as any medical profession could want them to be.
And it's a particularly vulnerable time for people as well, when people are already feeling pretty vulnerable and possibly scrutinised. So yeah, absolutely agree. Yeah, thank you. Did anyone else have anything? Okay, well, that is the end. I am going to say that's our last meeting until the new year. So I won't say the word yet, but I hope everybody has a lovely break at some point. Thank you.